to tonight's clinic, helping our patients during the cost of living crisis. Really great to see so many people of you here tonight, giving up your evening, a little bit of your evening at least, to help people that we look after who are having a bit of a difficult time at the moment. Just going to go through some introductions before we start, and then we'll get on with the presentation for you. So, my name is Andy Ward. I'm an inclusion health GP. I work in Leicester. I work in a practice where I look after patients experiencing homelessness. We also have asylum seekers in the practice as well. I also work at Leicester Medical School, where I have a particular interest in communication skills, and that's where most of my teaching takes place. And I've just become a member of the Stonygate Centre for Empathic Healthcare there, and we're looking to try and increase empathy across the medical curriculum and beyond that. We've got a grand opening tomorrow, a big launch that's happening in Leicester, which I'm really looking forward to. There's my email address there, which you can, if you want to, drop me an email after the talk. Very happy to take questions and requests for information after that. I've got a colleague with me tonight, Siobhan. I'm going to hand over to her to introduce herself and let you know what she's going to be doing this afternoon. I hope you can hear me there, Siobhan. Over to you.
I can hear you perfectly, Andy. Thank you very much. Lovely to be with you here this evening. Hi, everyone. My name is Siobhan. I'm a GP like Andy. Unlike Andy, though, I work in Oxford, which is it's a strange mix being in Oxford. There's obviously lots of privilege, but there's also lots of deprivation as well. There's an extraordinarily broad mix across the demographics. Obviously, lots of patients, lots of students as well, who haven't necessarily grown up in poverty, but are now experiencing it. So a very big mix of patients. I'm a university tutor as well, much like Andy, and I do this job as well. One of my roles within MB as well is to do the mental health course. I write and direct that, which has got lots of links with the cost of living as well, of course, hasn't it? Mental health. And I think Andy's going to be touching on that a lot this evening. I'm here to answer all your Q&As. So we're going to be really enjoying listening to Andy's experience and expertise on this evening. But it'd be lovely to hear from all of you as well. It is going to be very much an interactive, collaborative evening. Surprise, surprise, we don't have all the answers to the cost of living crisis, but we're just here coming together as like-minded people to see what we can do to help our patients' lives. So please do interact with us. Come and say hello in the Q&A box now. Let me know who you are, what you do, how has your day been? And then I'm hoping as the evening goes along, we can all share resources. We'll share them all out amongst each other. Do you know of a great local source or a great national resource that we can direct patients to? If you had experiences that you'd really like to share with all of us, anecdotes, please do interact with us. Let us know in the Q&A any useful tips that you've come across, because we really do want to know. We're going to be sharing this all out this evening. So come and say hi, and I will hand back to Andy for the rest of the evening.
Thank you, Shiv. And yeah, do keep Shiv busy. And you know, I don't pretend to have all the answers to all of this. I'm sure there's plenty of you out there who have a lot of experience working in deprivation, working with people who are struggling with their finances. So as Shiv says, please share resources. We'll develop them. We'll share that. We'll use them in future courses for sure. So what we're going to do in this evening is I've got four main aims for the session. We're going to talk a little bit about the background first and why this matters. Some of you will know a lot of this stuff already, but it's definitely worth talking about. And some of the statistics around this are pretty shocking. What should we suspect financial difficulties when we see our patients? What can be the warning signs that something is going wrong there that we should pick up on? How to then start asking those questions? How do we address it with our patients? And then finally, what can we do to help? And that's probably the bit that's most difficult for us as GPs. As Shiv says, we don't have all the answers and we can't just give people money. But there are ways that we can support people, and there are resources, lots of resources available for that. I'm going to be sharing some of those resources later in the chat, in the talk for you. So I'm going to start with the background and why this really matters. And it's going to start with a few definitions, really. So financial well-being. And this is the Money and Pensions Service who've come up with this definition. And it says it's feeling secure and in control of your finances, both now and in the future. Well, talking to an audience of GPs, and I suspect that most, if not all of you, actually do feel secure and in control of your finances, both now and in the future. But that reality is pretty rare amongst a lot of our patients who don't really know what's happening into the future as they get older. Knowing that you can pay your bills today and deal with the unexpected is part of that. So do you suddenly need a big bill on your car? Can you afford to pay that to keep you on the road? If your gas bill or electric bill is much higher than expected, can you pay that? That's what people need as well. And just being on track for a healthy financial future. Have you got a pension lined up? Have you got some savings perhaps to help your kids in the future maybe get their own place to live? So lots of that's what financial well-being is. And as I said, most of us on this talk tonight will feel fairly secure, have a fair bit of financial well-being, but the reality for our patients is often very different. And money is important. I'm sure you all know that. It helps to buy you the goods and services that improve health. And that includes things like healthy food, fruit and vegetables. I don't know if anyone saw Michael Marmot on Newsnight recently saying how actually buying a healthy diet is significantly more expensive than buying a cheap, unhealthy diet. So lots of junk food, it works out cheaper in the end. So being able to afford decent food is quite difficult for some people. Also being able to pay for physical activities, joining a gym, for instance, is a luxury that quite a lot of our patients can't afford. Managing on a low income is stressful, constantly comparing yourself to other people you see in the media, people you see at work, at schools, etc., and feeling at the bottom of that social ladder is pretty distressing for people. And that can cause stress, and we all know that stress causes ill health. And then behavioural differences for lots and lots of reasons, and I won't go into all of those. People on low incomes are more likely to adopt unhealthy behaviours, smoking, alcohol, those sorts of behaviours that we all know are bad for you. And then that reverse causation, if you have poor health, you're actually more likely to have a low income as well. If you have ill health in childhood, that can affect your educational outcomes, and that can then limit your job opportunities and potential earnings in the future. If you're having to sort of go through lots of medical treatment, it's difficult to get a job that you can be relied on. And why does this matter? Well, and why are we doing this now in the cost of living crisis? Why are we having this talk now? The number of people living in absolute poverty is forecast to rise to 40 million in the next 12 months. That's from 11 million, significant rise from 17 to 21% of the population. And that includes 30% of children. And that's not 30% of children from a deprived background. That's 30% of all children are predicted to be living in poverty over the next 12 months. And that's the highest level since the 1990s for that. And then there's fuel poverty. There's been lots in the news recently about fuel poverty and prepaid meters and all those things you've read about perhaps in the newspapers. That's going to increase to 14.4% of households in 2023. Now, if I worked this out, if you've got a practice list with, say, 10,000 patients on it, by law of averages, that means about 500 households in that list will be suffering from fuel poverty. It's a significant number of your patients are going to be affected in that. And obviously, if you're working in a deprived area, that's going to be even higher than that. And who is most likely to be affected by poverty? Well, people where the head of the household is from the Pakistani or Bangladeshi ethnic groups frequently come up in all these surveys as being in most likely to suffer deprivation. And it's important to think about that as different from the Asian group as a whole, because people from India do not fall into that group. They came to the UK for different reasons, often to work in the health service, for instance, whereas a lot of Pakistani and Bangladeshi households came over to escape conflict or natural disasters. So there's a different sort of deprivation levels amongst those groups. So that's if you're working with patients from those groups, you'll know there's a lot of deprivation within those groups. Next one. And working adults in workless families, around 40% of working age adults in a workless family will be living in relative poverty. That's compared to 11% in families where at least one adult works. So quite a big difference there. And I remember from lots of my GP work, families where no one in the house had worked for some time, and that's very challenging for them. If you're a social renter or a private renter, you're more likely to be living in poverty. 46% of social renters will be in relative poverty. 33% of private renters will also be in relative poverty. And that's compared to 15% of people who own their own home and 11% of those who have a mortgage. And if someone is disabled in the family, 23% of those families will be in relative poverty, again, compared to 15% of families where there's no one disabled. And mental health has an impact, as Shiv mentioned earlier on in the introduction. 1 in 5 people with a mental health condition will have problem debt. And there's a reverse causation with this as well. Half of people in problem debt will also have a mental health problem as well. So that's either as a result of having to deal with that debt or as a cause of it as well. So if you know people with mental health problems, and we have loads of patients with that, don't we? That can be a big issue for them. So health outcomes, and I've included this example here because this is one of the things that got me really interested in health inequality. I used to work as a GP in Corby, which is a bit of an unusual place in Northamptonshire. It was quite a small village in a beautiful area of the countryside, and then they decided to put a steelworks there, and lots of people came from Glasgow to work in this steelworks. So about a third of the population in Corby have a very broad Glaswegian accent. It's quite disturbing if you're in the middle of Northamptonshire. This pedestrian crossing that I show here is quite interesting because if you live on the left-hand side of the crossing, your life expectancy is 73 years. That's the Kingswood and Hazelwood ward. And if you live on the right-hand side of the crossing, your life expectancy is 83 years. So you can increase your life expectancy by crossing the road and moving house over that single road. And all of us in our practice areas will have these sorts of areas where there's a pocket of housing where people are living in deprivation. It's often very close to a pocket of housing where people are living in quite affluent conditions. And this life expectancy gap is pretty shocking when you think about it. 19 years between the most deprived and the least deprived in England and Wales. And if you think about all the work we do on statins and hypertension and diabetes, if we could get 19 years increased life expectancy for our patients from doing that work, we'd be really, really pleased with that. And that's just from deprivation, that difference. You're more than twice as likely to die prematurely from cancer. You're 4 times more likely to die prematurely from cardiovascular disease, and you're twice as likely to die from suicide if you live in the most deprived groups. And I could go on all night with loads of these pretty terrible statistics about health problems that people from deprivation suffer from. And the inverse care law, when we've talked about this on other NB medical courses that I've done, this is John Tudor Hart, who came up with this idea, a Welsh GP with a fantastic taste in hats. And basically what that says is the availability of good medical or social care tends to vary inversely with the needs of the population served. So in areas with high needs, inner cities, deprived areas, there tend to be fewer doctors, have higher numbers of patients, and those patients are generally sicker. There can be lower rates of immunisations, lower rates of screening, etc. And that can have an impact on those cancer deaths. And the way you put it very nicely, the extent that healthcare becomes a commodity, it gets distributed just like champagne. Rich people get lots of it, poor people don't get any of it. And this was written in the Lancet in 1971. It's pretty depressing that over 50 years later, we're still talking about it. Nothing has really changed about in that. And a quick word about inclusion health. As I said, it's an interest of mine. I work with people experiencing homelessness at work. You're probably familiar with these sorts of deprivation curves. This is looking at standardized mortality rates, where people in the first decile are the most affluent and people in the 10th decile are the most deprived. And you can see, obviously, those death rates are increasing as you go through towards deprivation. If you put homeless people in, there's a cliff edge. Their rates of mortality are 8 to 10, 12 times higher than the general population, even much higher than even the most deprived group. And this graph is looking at people who are homeless, but also prisoners, sex workers, and individuals with substance misuse. And the green line is actually women. Women do much worse in those groups. Life expectancy for a homeless person on average, 47 years for a man, 43 years for a woman. And if you think a third of deaths are from preventable diseases such as cancer, heart disease, diabetes, complications, for instance, we could be doing a lot more to help these people and help them to live a bit longer. And it's also a bit worrying when you think that Shelter are saying back in 2016, before the cost of living crisis, that 1 in 3 working families are a single paycheck away from homelessness. We could see a lot more deprivation, a lot more poorer health outcomes for our patients if that happens. So that's some of the background around why this is important, health inequalities and the impacts of those. I'm not going to go into any more detail on that tonight. There's loads of statistics out there you can read about it. I could spend a whole night talking about it. That's not quite the aim of the whole talk, but I just thought it's worth raising these ideas so you can see why it's important. I'm going to go to Shiv now just to see if there's any comments or questions that anyone has got from the audience about what we've said so far. Shiv, anything?
Thanks, Andy. Yeah, that's all really it's also useful, though, to put things into perspective, isn't it? I don't know if you saw there was a paper in the Lancet that was just published this month, highlighting the considerable sort of public health risk associated with the health inequalities, particularly with the most recent cost of living crisis. And their modelling they think that in just as really as a result of the fuel price rises, we're going to see an extra 500,000 cases of common mental health disorders, as well as increased death rates with that as well. So we've still got more and more of this to come, haven't we? And certainly, yes, all of our colleagues here are saying they've noticed a marked increase in deprivation, in people using food banks, and more poverty, and really being affected by recent inflation as well, and things getting worse. And certainly I know, as I say, I work in a pretty affluent city, but we still have the same difference in the life expectancy within the city. I mean, Oxford's tiny. We have a 15-year age gap between one side of the city and the other. So that marked inequality is unfortunately being replicated all over the country, isn't it? More people coming in saying, so many people living in poverty in their area, and the system's so difficult to navigate. And of course, and talking about our wellbeing workers, our health link workers, they're the social prescribers, they are really coming into their own, aren't they? Being kept super busy. And I'm sure you're going to be talking about that a bit more, aren't you? I don't want to take up too much for time, because I know you've got things to get through. So I'll let you carry on. Please do keep all of your comments and let me know your experiences. It's really helpful to know. And also any useful things that you've come across, that would be great as well. So I'll come back to you, Andy.
Thanks, Shiv. Yeah, and actually, I've heard people talk about a bus ride. You're on a bus ride through your town. You'll go through so many areas of deprivation and great affluence, and it's quite shocking to see the difference between the areas. Okay, so the next part of the session, I just want to talk a little bit about when we should suspect financial difficulties. And Shiv mentioned people using food banks and things. And I think sometimes that's quite obvious. You see someone like that, and you know they're having financial difficulties, but it's when you should maybe suspect in a patient who isn't so upfront about what's going on in their life. We're going to use an example to help with this. This is Jacob. Jacob is 52 years of age, and in his records it previously mentions that he works as a warehouse worker, and he's booked a telephone consultation with you because he was refused a repeat prescription for his salbutamol inhaler because the doctor who was doing the repeat prescriptions that day said he was over ordering and he hasn't been attending the asthma clinic, so he refused to issue it until he had a review. And when you look at his records, he's not been ordering his inhaled corticosteroids. So I'm going to go to a question here for you. And I want you to just be honest on this, because we don't know who's answered what you put on this at all. I just really want to get a feel for what you would actually do. Would you honestly think at this point, I'm going to ask Jacob about financial difficulties, or is it something would you be focusing on the inhalers or his asthma management? So just be honest, and we'll see what the feel of all the people who are on the webinar tonight would do. It's quite a little snap survey of general practice, perhaps, to see where we are with this. There is a bit of a delay on this, so I'll just wait for the answers to come through. I think it's in case I collapse or start sort of swearing loudly at something, so Daniel can quickly cut us off. We've got Daniel in the background, who's our technical guru. If he sees me do something really bad, he'll cut me off. Or Shiv, could be Shiv. Okay, let's see what we've got. Quite a great response rate here. Let's see what we're doing. So actually, yeah, about 80% of you would not really think to ask about financial difficulties, but interestingly, 20% of you would. And I don't know, because we've got a particularly interested group on the call, because I suspect if we did this survey across the whole of general practice, we might find that 20% to be a little bit smaller. So when I was trying to think about how you would pick up on a patient with financial difficulties, I think it worked quite nicely to separate it into that triple diagnosis, that medical, social and psychological signs, as I think we probably remember from medical school. And you think about medical and physical things, it could be not ordering all repeat prescription items, or perhaps not collecting those repeats that have been issued, probably because the patient can't afford to pay the prescription fee, so they're avoiding taking them. And when that happens, I'll tend to concentrate on picking up those ones where they feel an improvement. And so salbutamol, they can take the salbutamol, they can feel their chest improve. Inhale corticosteroids, they take it, they don't really notice the difference. So they're going to prioritize those drugs that they feel are the most important. You might find someone on a list of repeats is maybe only ordering one or two of those repeats on a regular basis. Missing appointments, including telephone appointments. If someone has to work, they may be working shifts. If they don't turn up for work, they don't get paid. They're going to find it difficult to fit into appointment systems. And Shiv's actually doing an extended hours clinic as soon as we've finished this talk tonight. And those are sort of patients who may need access to those clinics. They often get snapped up by patients who have got flexible hours. But people who are working in warehouses, for instance, like Jacob, and they're on a 0 hours contract, they may not be able to take time off work to get to the doctors. And sometimes if you ring someone, they might say, I'm at work, I can't take the call. Can you call me back later, for instance? You might notice a poor diet. Someone might be losing weight from not eating enough, or the opposite. They may be putting on a lot of weight because they're eating unhealthy food. As I mentioned, unhealthy food is cheaper. And you might notice obvious things like they look a bit like the clothes aren't very clean. Maybe they're not the shoes have got holes in them, or the clothes look like they've been repaired. Issues with personal hygiene, perhaps not washing as often as you'd expect. Haircut, badly in need of a haircut, for instance. These could be signs that someone's struggling with their finances. Socially, if you know where they live, that can help sometimes to warn you. As I mentioned, we know the areas in our practice areas where there's a lot of deprivation. But if they're renting, then can be a sign. Homelessness, and within that, I would include people who are sofa surfing, maybe staying in bed and breakfast or hotels, maybe staying with friends. People who don't have a secure accommodation would be included within homelessness. Work issues, they could be looking for fit notes quite often, or the opposite. You could be offering them a fit note. You really feel they need to have a bit of time off work, stress or anxiety, and they're refusing to take the sick note because they don't want to lose any income. And then withdrawing from social activities, becoming more isolated. Sport, I'm a big football fan. I love Sheffield United, and I'll be going to see them at the weekend. That's about £100 for me to get there up to Sheffield and get to the match, pay for the ticket. And that's quite a luxury to go to football now. It didn't used to be when I was growing up. So people might, you've got those patients who used to talk about their interest with them when they come to see you, and suddenly they've stopped doing them. That might be a sign. They may not be traveling on holiday or traveling to see family who live in cities elsewhere because they can't afford to get to them, or they've had to give up their car or something like that. And they've got caring responsibilities, that pressure to sort of be available for that family member to look after them means they can't take up work perhaps that they want to, or they can't work as much as they need to. And if they've applied for or are receiving benefits, obviously that's a warning sign too. And psychological, this is getting into Shiv's course really a little bit. Mental health issues, depression, anxiety, clearly they can be signs. And again, there's that reverse causation with that. If you've got depression and anxiety, you're more likely to be suffering financially because you might find it more difficult to hold down work. Self-harm, if you're ashamed about your financial situation. Insomnia, and then substance misuse. Alcohol and illicit drugs, perhaps to numb the sort of pain of it all, but also the reverse causation again. Maintaining an alcohol or drug habit uses quite a lot of finances up as well. So, and this information was produced by the Office for Health Improvement and Disparities. It's a really helpful document, and I'll include a link for it in the resources so you can have a look at that later on. And they've got some advice for us as frontline healthcare professionals. Take a bit of time to reflect on it. I know you're doing that by attending this course tonight, but how someone's financial situation could affect all aspects of their everyday lives. And then ask the patient about their financial well-being as standard. And that's quite a thing, isn't it? Because I don't think we do it as standard now. I mean, 20% of you were sort of thinking of doing it with Jacob. And I was thinking about this and thinking, actually, we've got so much to squeeze into a consultation, and this is yet another thing to squeeze into a consultation. But I remember I've been a GP I worked out, actually, it's 25 years last week. And at the start of my training as a GP, actually, people used to feel a bit awkward about asking about alcohol or asking about smoking even, or asking about sexual history. And I think now those have become a little bit more standard in our daily practice, where I don't think this financial well-being has, and it needs to sort of become standard. They do acknowledge that time constraints can be an issue, and you can't ask about it in every interaction because it is going to take time. But if you do notice some concerns based on the sort of things I was just talking about, then you should try and weave it in, or even just make a note in the record that you have some concerns about it to perhaps come back to in a future consultation. So that might be something else you could do. And we need to just sort of start to normalise this conversation about money and show that you as a GP are not embarrassed to talk about it. And that can help to reduce the embarrassment that the patient might be feeling when you're talking to them about it. So definitely something to think about. And that moves on to the next bit, really. And I mentioned in the introduction that I'm interested in communication skills. That's my main role at the medical school. So I was really interested to think, how do we ask about it? What are the communication skills that we might need to do it? Turns out they're really simple. And it's based on very brief interventions. And I think we're all very familiar with very brief interventions because we've used them with smoking and other lifestyle issues. Just ask. And the question is it okay to ask about your money and finances? And that's quite a nice, gentle question to open the conversation. It allows the patient to say, no, it's not okay. Actually, I don't want to talk about that. And it's just, if they have got a problem, they will raise it at that point. So start with a nice, gentle question like that. And then if the patient just reveal that, yes, they do have problems with money, then assist is the next step. And again, very, very simple. Can I share some information about free services that provide impartial advice on money? So we're not asking you to solve the person's financial difficulties. You're acting as all GPs do in nearly everything we do. You're signposting them to the best person to help them. And it's really important that you give guidance and not advice. And it's that distinction between advice and guidance is important, because if you start to give financial advice, you're starting to get into the financial conduct authority and starting to become a financial advisor. And if you're a financial advisor, you need to be properly trained, you need to be insured, you need to have all the right qualifications for that. So you should be giving guidance, not advice. And what's the difference? If you're telling them that you're going to refer them to an organisation like Citizens Advice, for instance, to help them decide on what benefits they might be able to claim, that's guidance. But if you're saying, actually, there's a bank down the road that's got a really good interest rate on loans, I think you should go and get a loan from them. That would really help you. That's advice, and you can get into trouble for that. So don't do that. I'm pretty sure you wouldn't do that. But the documents I referred to, they just make that distinction very clear. And then ACT is the final bit. Signposting to these free, impartial and trusted sources of support. And I'm going to share those resources a bit later on. There's a document available for you as well to download with all the links to that. So we'll come to that in a moment. There are some other things you should bear in mind. You do need to be sensitive in your approach, and particularly if you're working with diverse groups of patients, cultural awareness is important. Different cultures have different views about finance, and it can be very embarrassing or difficult for some cultures to admit to problems around their finances. So if you're not from the same group, try to be cautious, try to avoid causing offence. And if you're supporting someone who doesn't speak English as their first language, you may want to think about getting an interpreter, and if possible, a professional interpreter from outside the local area who might not, so they don't really know them or know their family, so they feel more comfortable about talking about any financial difficulties they have. And also just to make sure you're not getting things confused, you're not using terms that might mean one thing in a different culture. So just to be aware of that. Capacity as well. If you've got someone who you don't think has capacity, who's making rash decisions about their finances, then just go through your local policies and procedures. You need to ensure that you're compliant with the Mental Capacity Act, and I'm sure you'll have practice protocols to help you through that. Safeguarding also can be an issue. If you think the person is a victim of safeguarding and being financially abused by a partner or a family member, clearly you need to go through your safeguarding protocols. But also if their lack of finance is leading to neglect of their own family, then again, go for it. Don't be worried about using safeguarding guidelines to help through those sorts of scenarios as well. Okay, I'm going to go back to Shiv and see what else you've been talking about whilst I've been going through that bit.
Thanks, Andy. Yeah, lots of things. One of the things, of course, which you and I, Andy, don't benefit from is free prescriptions, as people do in Scotland and Wales. So, yeah, absolutely. Hooray for that. Wish it was the case across the board. But, yeah, it's definitely an issue where I am as well, the cost of prescriptions, and it for sure affects people. And it's a lot easier to ask my students because they're all quite upfront. I've got no money, I'm a student. But it's more difficult to ask adults who are working and living in poverty. And you raised that really good point. I'm really glad that you talked about that, Andy, about how to ask about it, how to approach it. It sort of reminds me a bit about the technique I use for asking people about their weight. You have to find the right moment. Have you got the time to unpack this conversation and approach it sensitively and not in a hurry? And as you say, sometimes it's not really obvious. And I can think of, we have quite a lot of asylum seekers where I am. And there's one particular family, and we just didn't understand their circumstances until one of the health visitors went to go and see them in their hotel room. Unfortunately, they were like in a hotel alongside lots of other people. And, reported back on the horrendous, just completely horrendous conditions of 5 of them living in one room with one microwave. And we certainly hadn't grasped that at all because they were, very proud, didn't want to actually talk about how dire the circumstances are. But yeah, it's definitely a sort of a common problem. One of the other things that I think is the thing that we found helpful in our practice was actually one of our medical students did this. He had a real burning interest in this, and he did a search using different criteria, which you can get from things like Greener Practice, which we're signed up for, to help you search for your patients who may be living, particularly in fuel poverty. We did this before the winter, trying to identify those people and then, approaching them with our social prescriber to see what else we can do. So if you're wondering about where are my patients, it may be really obvious to you, but if it's not quite so obvious and you're thinking, should I be doing something more proactive? There are different searches that you can do based on criteria that will help you to identify those patients perhaps a little bit more easily. It's someone saying, if you're asking about it, if they say they're okay to be asked, what are your follow-up questions? What do you do next? I guess it could be multiple things. I'll come back to you, Andy, about that in a moment, about how would you follow up with that? I guess, how is it impacting you and, in your life, your food budget, feeding you and the children? So are you missing out on food? I think one of the other big things which is really important to ask about is hygiene poverty. And we often forget about this, but actually it's really important. Are they able to get the right amount of hygiene products, whether that's simple stuff like soap, shower gel, but also menstrual products, because they're expensive and they're really important. And people might not know how to access that. And you can get that through food banks. There's a great charity called Beauty Banks, which you can contribute to, who set up a process to distribute hygiene products across the country to people. And going through food banks is usually the best way of doing that. Have you got any other things to add to that, Andy?
Thanks, yeah, some really great points there. And I think actually the asylum seeker one is very interesting, because when people get status, so they get granted refugee status, their problems don't end there. And if you've been an asylum seeker in the UK, you're not allowed to work as an asylum seeker. And that it could be 2 years waiting to get given refugee status. So then to get a job when you get refugee status is actually really difficult. You never worked since you came to the UK. And so we see in our practice, people get the asylum seeker status, they get granted refugee status, and you think, oh, great, now they're going to be sorted. But actually, no. they lose their housing, they have to either go on benefits, which can take time, or try and find a job, and often they end up homeless at that point. So if you've got refugees as well as asylum seekers, refugees often are even worse off than the asylum seekers, I think. What would you ask next? I think it's the question I always like to I bang on about this to our medical students, just tell me a bit more about that, is always really good, because if the patient then will go off on the tangent that is important to them. So it may be, as Shiv said, that they can't afford their hygiene products, but it might be food, it might be worried about the children, it could be anything. But actually keeping the questions really open at that point will get you to find out much more information about what matters to them. I think that's where you need to sort of direct it. But if you wanted to ask specific questions, I'd probably come back to those points I mentioned earlier in that medical, psychological and social thing, and just go through some of the points there. Are you ordering all your prescriptions? Are you eating? Are you getting enough food? Those things, as Shiv's just pointed out. But yeah, really great question, that one. Okay, so if we're okay, I'll go on to the next part of the talk now, just to wind it up, really. We're doing well for time, so that's good. So really, this is probably why most of you are here, actually, I think, is to think about what can we do to help patients in these situations. And this can be a little bit difficult, I think, for you. And in some ways, I think people maybe are a bit reluctant to ask the question about finances, because there's a feeling that what can we do about it anyway? If we do ask, well, hopefully by the end of this next section, you'll have some ideas about that. Now, benefits. So benefits are a bit of an opaque thing, aren't they? They are complicated and difficult, and they always seem to be changing. And I just want you to have a little think here. And again, being honest, you can choose as many of these options as there are on there. You don't have to choose just one. Thinking back to Jacob, we know he was 52. We know he worked in a warehouse possibly and had asthma. Which of these benefits do you think you could advise Jacob to think about claiming for? So you'd need to get a lot more information from him to make a decision. But just I think, do any of these benefits that I've listed on there sound like they'd be ones that might be of interest to Jacob? So we've got job seekers allowance, universal credit, carers allowance, employment and support allowance, personal independent payment, and attendance allowance. So just choose as many of those that you think you might sort of consider recommending that Jacob thinks about applying for. And if you know the answers, I'll be impressed. It's extremely complicated, the benefit system. One of my good friends has done a lot of work with people on benefits and helping people with that. And I got his advice before this talk, because no matter where you look online, it's actually very, even for me as a doctor, to try and find out what's going on is actually pretty complex. I'll just give you a chance. It's great so many people still here, still taking part, having a bit of a think about this one. It's a bit more of a difficult question, this one, I think. Just give you a few more seconds for those of you who are still thinking. Okay, let's have a look what we're thinking. So job seekers allowance, about a fifth of you thinking about that. Job seekers allowance is no longer available for new claimants. It's been absorbed into universal credits, and I'll go into a bit more detail about the different benefits there are in a bit later on. Carers allowance, yes, possibly if he is a carer. So if he's looking after somebody, you might be able to claim for that. Employment and support allowance, again, that's no longer available for new claimants, has become part of universal credit. PIP is available for people with mobility issues or disabilities, for instance. And attendance allowance, that's for elderly people who have care needs, and it's claimed by the elderly person rather than the carer. And it's not means tested, so it's available for anyone who has any sort of care needs in their old age. I'm just going to go through some of those benefits now, just in a little bit of detail, just to give you a little bit of a feel of them, so you're aware of the sort of things that your patients may be claiming. Patients often mention their benefits to you, and they want various bits of information from you as a doctor to help with them, don't they? So it's sometimes quite a good idea to just go through them in brief detail. So personal independent payment, that's extra money to help you with everyday life if you have an illness or a disability or a mental health problem, it's about £60 to £100 per week. And you need to have help with daily living tasks. So washing, dressing, making decisions, socialising, or mobility issues. So, and that's what they get, £60 to £100 a week. You'd think it was thousands of pounds when you read some of the newspaper stories about benefits, wouldn't you? Universal credit, that's, as I said, it's replaced quite a few benefits that used to exist. So housing benefit, there's ESA, the job seekers allowance, child tax credit, working tax credit, income support. You've probably heard lots about those benefits in the past. You can get it when you're working, depending on how much you're earning. And it's between £250 to £500 per month, approximately. You get supplements if there's disability or housing issues as well. And universal credit, it got quite a lot of bad publicity at the very start, probably because its introduction was so badly managed. But in a way, it's quite a good idea because it's simplified the benefit system in a way, and it is available for people who are still working. So there are some benefits to it, I think, if it eventually gets sorted out. Pension credit, you've got to reach state pension age, and it's means tested, so it depends on your income and savings. You've got to live in the UK, so you can't go and retire over to Marbella and send your claims in. And it's about £15 a week, so not a huge amount. And then the carers allowance, if you spend at least 35 hours a week caring for a disabled person and earn less than £132 a week from employment, after deductions, that is, you can get about £70 per week. The person you're caring for must also be claiming benefits. Now, don't expect to remember all those. They're the four main benefits that are available in the UK at the moment. If you want to help your patients know which benefits they could go for, there's this really excellent website, Turn to Us. They can go into that, they can enter all their information into the calculator there, and it'll tell them what benefits they're entitled to and how much they can claim and how to claim it. So it's a really useful website for those patients who you think might be able to claim benefits. Just bear in mind that 11 million people in the UK are unable to use the internet effectively. They don't have the digital skills required. And about 5 million people never go online at all. And you won't be surprised to learn that most of those people are the most deprived people in the country. So the people who really need to get access to this website are sometimes the ones who are unable to access it. I'll come back to what you can do about that in a moment. There are some other sources of financial support, and these are usually from local authorities rather than from the benefits agency. They can claim council tax discount, exemption or support. Again, it's means tested, and they can get about 80% discount on their council tax bills if they're successful in that claim. They can get a discretionary housing payment, and that's if you need a deposit for a house you want to rent, for instance, or you need some rent in advance. If you're moving home, we've got a rent shortfall, you can apply for a discretionary housing payment, again from the council. Travel passes, really, really helpful for our patients who need to travel for hospital appointments, etc. They can get free public transport with a travel pass. The form is draconian. You've got to really almost like be unable to walk more than about 4 steps before you fall over to claim for it, but it's worth having a look at that for those patients who are struggling to get around. If they're not allowed to drive because of alcoholism or drug problems, they can apply for a travel pass if that's the case. And there is the NHS low income scheme, and your patient, and this is obviously in England, you mentioned, Shiv, helpfully about the free prescriptions in Wales and Scotland. But if your patient is paying for prescriptions, they may be eligible for free prescriptions. They can apply for something called an HS2 certificate or an HS3 certificate, which partially helps with their payments, and they'll get free dental care, free opticians, all the things that you can normally have to pay for within the NHS. Again, really helpful website there. They can go in there, they can enter their income, their savings, etc., and it'll tell them whether they're entitled to that, and then go through the process of applying for that. It's a useful thing to know about. So who can you signpost to? And this is where we get to what Shiv was saying before. Social prescribers, absolutely brilliant for this. If you've got a patient who really struggles to use the internet and you think they want them to go through that website, Turn to Us, get a social prescriber to sit down with them and go through it with them if they can. If they've got time to do that, it'll really be a great way to do it. And make sure your social prescribers are aware of all these different websites that I'm going to mention now. Money Helper, that's backed by the government. It gives impartial guidance, and it can recommend further support if people go through that site of where they might be able to get support locally, for instance. There are useful tools in there to help people who are struggling with the cost of living, how to prioritise your bills, pension advice, how to deal with creditors, example letters that you can send to the creditors, for instance, if you're struggling to pay a debt. So that's a really useful website. Citizens Advice, which I'm sure most of you have heard of, again, very, very similar to Money Helper, free impartial advice, but then you can actually go and speak to a real person, which can be helpful if they're struggling with the internet. Trussell Trust, you've heard of that, I'm sure. Well, that will give a list of local food banks, and they'll find out where they can go and get food if they need it. Great charity. Shelter have loads of really helpful advice about housing, and that's particularly useful for people who are facing evictions in private rented accommodation, for instance. So I'll give them advice on what their rights are, what they can do to avoid eviction, and also can help them to make sure that their tenancy is legal and fair and they're not being ripped off by their landlord. Mind has got some really great stuff on their website for people who are suffering from mental health problems and financial difficulties. And there is something called breathing space, which I don't know if any of you have heard of. If someone's suffering from mental health problems, they can apply to have their debts suspended for up to 60 days with this breathing space scheme. It is supported by the government, and the debtors are not allowed to enforce the debt whilst they're on that scheme. They don't write off the payments, they still have to pay it off after the 60 days, but it gives them time to maybe get over their mental health problem or relieve stress or anxiety as a result of it, and maybe restructure their debt in that time period as well. If they're under crisis treatment for mental health, they can apply for even longer with that. They can get a longer period of deferment, and they can apply more than once in a year if they're under crisis. They can only apply once a year if they're not under crisis. Really great scheme, though, for a lot of our patients. Imagine if you're absolutely struggling with your finances and a desk banging on your door, your risk of self-harm or suicide is pretty high. So that's a way of avoiding that. And then Macmillan Cancer Support. If someone in the family gets cancer, that can be a big problem for families who are struggling financially, particularly if they're the main earner. And Macmillan have got loads of resources to help with that and how to claim the benefits you're entitled to and how to get support with that. So I recommend that. And then finally, the last one I'm going to share with you, and if you've got any more, please share them in the chat so we can share them with everyone else. This was one of my patients showed me this the other day. It was really interesting. It's this Olio app. It's like a sharing app. It's not just for food. People who've got a bit of furniture they want to get rid of, for instance, and put it on this Olio app, and someone will come and collect it. But supermarkets and takeaways, when they've got excess food, put it on this Olio app, and people can then bid to get it free. So they go on the phone and they just say, I'll take that. And then they just go around and collect it. And he was getting all his meals from this app. So he was going around to the supermarkets and claiming this free food through the app. So I'd recommend that to patients as well if they've got a phone that it will work with. What else can you do as a practice or personally, I guess? It's interesting to understand the local needs of your community, and you can go on this Fingertips website that Public Health England have done. You can sort of look at the statistics based on the council wards or the local area and see what are the issues. Have you got higher than average cancer rates? Have you got higher than average suicide rates? Things like that. Just drill down on the data and see where the deprivation is in your local area and understand, you might be sitting there thinking that your area is quite well to do, but it turns out it's not. And just be aware that deprivation has really negative effects on the health of your population, and reset your thresholds. So if someone's getting chest pain in their 40s and they're from a deprived background, more likely to be cardiovascular than, say, if they're from an affluent background where it might be in the 50s or 60s before it becomes an MI. Cancer's more coming at lower age groups in deprived communities. So just reset your thresholds if you're dealing with deprived patients. Find out what charities are active in your area, because there will be national charities, but there'll also be quite a lot of local charities in the area that help too. There's loads in Leicester where I work who help our homeless patients. I'm constantly calling on them for support. And find out if there's anyone in your organisation who can help. And we've got a lot of staff working for us, some of whom are quite active in local charities too. They might be interested to do something around this or to try and help patients. Medical students, you mentioned medical students, Shiv, in your bit. In my old practice, we got our medical students to set up our social prescribing program before social prescribing became a thing. And they actually ran it and went to all the charities and found out what the charities could offer and created a fantastic directory, which the social prescribers still use, as far as I'm aware. They also helped me with a vaccination clinic and did health checks on homeless people as well. So used medical students, registrars who were looking for a quality improvement project, the social prescriber, as I mentioned before. And you could even run a campaign in the practice, maybe put some leaflets out from Money Help or some of the financial support organisations I mentioned. But if you're going to do posters or drop-in sessions or leaflets, just think about literacy, make sure they're in a really easy to understand format, and try not to make it all about the internet, so you're not excluding those patients who don't have access to the internet. What about Jacob? Let's go back to Jacob and let's find out what happened with Jacob. It turned out he was struggling financially. He was caring for his sick mother. He wasn't ordering his inhaled corticosteroid because he didn't feel like it made any difference, and he could only afford one prescription charge. And as we suspected, he was on a 0 hours contract at his local warehouse, and he couldn't get to appointments in working hours as a result of that. He was struggling to keep up with his rent. So we referred him to our local social prescriber. We went through the Turn to Us website with him, and we found out he was entitled to universal credit and a carer's allowance as well. We reviewed his asthma. We got him on a combined LABA and inhaled corticosteroid inhaler, so he's only paying one prescription charge. His control improved as well, so he was a happy man, or happier man. Just to conclude, really, before we go back to Shiv to find out what else you've been saying, increasing numbers of our patients are going to be facing poverty as this cost of living crisis spikes, and it's not really showing any sign of improving for us at the moment. And we should be thinking about the financial well-being of our patients as standard, as it said. That's just yet another thing that can cause people to get ill, along with lifestyle and all the other things we need to think about. Look out for those warning signs, just be aware of those and be ready to ask if you suspect something's going wrong. Normalise that asking about finances so it becomes something that you just do. You're not embarrassed about it, helping the patient to not be embarrassed too. Although remembering to be sensitive in those groups, which might find it difficult. And then just signpost to appropriate support as you need to. I'm just going to leave one last slide before I go back to Shiv. Michael Marmot, if you're interested in health inequality, Michael Marmot is like a bit of a saint or a hero around this. He's done so much important work on it. He always speaks so well about it when you see him on the news. There can be no more important task for those concerned with the health of the population to reduce health inequalities. Well, we're concerned with the health of our population, I would say, and we don't need to just the little things that I'm talking about today, a little bit of signposting, just asking about it, being aware of it. That can be enough to help to reduce health inequality. We're not going to make them go away completely, but we can reduce them a little bit. Okay, I'm going to go back to you now, Shiv, just to see what everyone's been saying about that.
Thank you. There's a really good point that's just come through, which I've just replying to, and actually a few more of you are saying the same thing. In that, a lot of this, the things that we want to do are also the things that contribute to our own burnout as well. And this is a really tricky area if you're working in a deprived area, or if you're the person who is kind and empathic in your practice and you attract this workload, this group of patients, you're generating this workload for yourself that may be disproportionate, maybe taking up a lot of your time and also a lot of your emotional resources as well. Let's be honest, because we all experience that emotional transference from our patients, and we can feel the despair and the sort of helplessness there. Absolutely. It's really difficult, isn't it? I don't have the answer for that, except to say, that kindness and empathy is why we do our job in the first instance, and it really does make a difference to people's lives. So don't stop doing it. Try and inspire your colleagues to be doing the same, so you're sharing the workload. And one of the things I just mentioned to someone now is, if you're in an area where, and even if there will be within a radius, there will be a medical school, and trying to involve medical students at an early age, at an early stage, into this kind of altruistic behavior is really important. And every time we have a student, we try and rope them into various different things, but trying to get them involved. First of all, it opens their eyes to what their patient demographics are going to be like, but getting them involved in helping you with that work is really important as well, because they're going to have to be doing this for the rest of their careers anyway. Someone else has been asking about, are these financial supports available across the UK? Yes, they are. And I've sent you some links, and the certificates are available as well, sort of across the UK. There's obviously going to be regional variation, isn't it? And that's always really helpful, actually, just to think about that regional variation in terms of actually what's available in your area. And hopefully your social prescriber will help you this. But it'd be great to, if you're not really sure what's available, then perhaps asking your social prescriber to gather you a list of all the local charities, the local warm hubs, the food banks, all of those kind of things, what local council help there is there local transport help for getting patients either to see you or to hospitals so they don't miss out on their appointments. One of the things that we've got quite a lot of elderly people in our practice, and we have to be mindful of the bus time change for when their bus pass becomes free, because it's not all day long, it's not in peak times. So, or I will just always, I'll book, if I've only got a 9 o'clock appointment, I'll book it, but I'll say to them, come at 11:30 at the end of the surgery. And that makes a significant difference to people because our bus fares are horrific. So that's really helpful just to sort of understand about those kind of things as well in your area. Someone asking a quick question now, do you find that doing housing support letters is actually helpful? Controversial. I don't know is the really honest answer. I do them. I think it makes some difference. And obviously you can escalate your wording, and you can, depending on how significant you think it is. It's tricky. I don't think there's a really a dead cert answer to that. Maybe we should get somebody who actually works in housing to let us know whether they just make a big bonfire out of them or actually whether they really do make a difference. I like to think that they make a difference, and we certainly write them. But it's a pretty pertinent question. I don't know the honest answer, really. I wonder, Andy, if you've got any insight into that.
The problem is there's just no housing. So the right to buy scheme has actually wiped out most council social housing, and they haven't had the budgets to build more social housing. So if you're a single male, for instance, your chances of getting housing, social housing, are virtually nil in the next 2 or 3 years. So your letters might help if it's a family, or might help if there is a real health problem or a disability or mental health problems. But they just added to another list, just maybe a little bit higher up a different list. But yeah, it's worth doing them, and it's worth maybe having a template to help you do them well and help them be meaningful. It does feel, yes, another task for us to do, but we do a lot of housing application letters or housing support letters in the homeless practice. And we have a little bit of a template to help us do them and make them effective. So that's perhaps a recommendation I would say about that. Thank you. Any other points, Shiv, you wanted to?
No, I think it's been incredibly useful, and lots of people coming in with, similar, we're all having the same sort of issues, aren't we? And we're really noticing the impact on our patients. And I'm so thankful that we do have our social prescribers, because they are super busy now. Tapping into your local resources is definitely really worthwhile doing, because there really may well be some things that you don't know about that are doing great things. And that's sort of one of the things that I found there's a lot of requests here for the housing letter template. I don't know if that's a standard one that you've got that you could share.
Not to hand, but if anyone wants to email me after this talk, I'm very happy to forward some ideas for that. Some of the charities also have got some advice on what to write in housing support letters, so I'll send some links for that as well. Okay, great. Some Really nice. I think we're about out of time, Shiv, actually, now, aren't
Yeah.
we? I would absolutely support your idea to get medical students involved. Medical students are really quite a good bunch of people generally, and often altruistic. And one thing they've got that we as doctors really don't have is quite a lot of time. So if you can get medical students involved in this sort of thing, they think it looks great on the applications for jobs as well. So it's not entirely altruistic. So getting to do stuff like that can help. Final point, as mentioned, empathy. I'm doing the Empathy Centre launch tomorrow. Actually, the evidence is the more empathic you are, the less likely you are to burn out. Just bear that in mind. I'm going to hand over to the final slide. Please give feedback on this. The first time we've done this course today. This is a new course for NB. It'd be really great if you could fill in the survey. I'm sure there's bits we can improve, but anything you want to say about this evening would be really helpful for us. We do read it avidly, and we do take on board the things that you put in there. So please finish the survey before you log off to enjoy the rest of your evening. And thank you for joining us. And it's been great. And thank you, Shiv. And thank you, Daniel, for your technical support. Good night, everybody.